All right, are you ready to absolutely crush your respiratory pharmacology exam? Welcome to this rapid-fire explainer where we're going to take some pretty intense clinical data and transform it into the exact high-yield concepts you need to know. We are totally cutting out the fluff today and giving you just the hard-hitting facts on respiratory drugs. So if you're a nursing student looking to completely dominate your next test, you are in the perfect place. Let's get your brain in gear.
Okay, let's dive right into this. Our bootcamp syllabus today is incredibly focused. We're going to conquer 3 key sections. First up, bronchodilators, looking at rescue versus maintenance. Second, anti-inflammatories. And third, antitussives.
So, Section 1, bronchodilators, rescue versus maintenance.
Now, these drugs really are the cornerstone of respiratory therapy, right? They relax that bronchial smooth muscle to dilate airways that have narrowed up. But here is the absolute secret to clinical success, and honestly, to passing your exams, it is all about the timing. When comparing your options, your short-acting beta agonists, or SABAs like salbutamol, which you probably know as albuterol, these are your immediate rescue inhalers. When a patient is having a terrifying acute asthma attack, this is the exact drug you reach for because it works right now. On the flip side, we have long-acting beta agonists, LABAs like salmeterol. These have a longer onset of action, and they are strictly used for long-term maintenance and prevention. You have got to remember this. A LABA is never ever used alone for an acute attack. Literally, if you give a LABA during a severe asthma attack, it's just not going to work fast enough and your patient will be in serious trouble.
And when we really dig into the exact dosages and delivery routes for these critical bronchodilator medications, it brilliantly illustrates how targeted this therapy can be. Notice how medications like ipratropium bromide, which is an anticholinergic, alongside our beta agonists like salbutamol and salmeterol, are so frequently given via metered-dose inhalers or nebulizers. That targeted delivery brings the drug right where it needs to go, directly to the lung tissue. That maximizes the bronchodilation effect while doing its best to minimize those pesky systemic side effects.
But of course, systemic side effects still happen, and the NCLEX absolutely loves to test you on them. Take salbutamol, for instance. Because it's a sympathomimetic, it could actually stimulate beta-1 receptors in the heart, along with the beta-2 receptors in the lungs. What does that mean for you as the nurse? It means you have to watch your patient for tachycardia, tremors, palpitations, and restlessness. Now, for our anticholinergics like ipratropium and tiotropium, you've got to remember their mechanism. They block acetylcholine on the bronchial tree to prevent bronchoconstriction. And think about it. What happens when we block the parasympathetic nervous system? Everything dries up. Literally everything. So you should fully expect a dry mouth and throat, and you'll need to instruct your patient to increase their fluids if it's not contraindicated.
Okay, time for our first set of rapid-fire bootcamp drills. Scenario 1. Your patient is wheezing and gasping for air. What's your move? Boom, you hand them a SABA, like salbutamol, for immediate rescue. What if you only have salmeterol on hand? Do not use it. LABAs are for daily maintenance only, never an acute attack. Next up, why is your patient on albuterol suddenly reporting a racing heart? Well, because high doses cause the drug to lose a bit of its selectivity. It starts stimulating those beta-1 receptors in the heart, leading to tachycardia. Moving on, why would you prescribe ipratropium for a COPD patient? Because it's an anticholinergic that blocks acetylcholine, preventing bronchospasm and reducing all those secretions. And finally, what's the primary target of a respiratory beta agonist? Beta-2 receptors. Why? Because you have 2 lungs. Beta-1 is for the heart because you have 1 heart. Remember that trick? It's a lifesaver.
Whew! All right, take a quick breath. You are doing absolutely great. Hey, if you're finding this explainer helpful, make sure to hit that like and subscribe button for the Nurse Crush It channel. We've got so much more content to help you keep crushing your exams. All right, break's over. Let's get right back into the heavy-hitting pharmacology.
Section 2. Anti-inflammatories, steroids, and LTRAs.
So, while bronchodilators open up the airways, anti-inflammatories fix the underlying swelling. We are talking about drugs that stabilize cell membranes and drastically reduce the chemical mediators causing airway edema. Now, what's really interesting when analyzing systemic glucocorticoids is the stark differences in their potency and duration. For example, look at dexamethasone. It's a long-acting, highly potent synthetic steroid that requires a much smaller equivalent dose. Literally just 0.75 milligrams compared to a full 20 milligrams of naturally occurring hydrocortisone. This is absolutely vital when you're transitioning patients between different types of steroids, just to ensure they're getting a therapeutically equivalent dose without risking a dangerous overdose.
Let's really hammer home the absolute must-knows for steroids, because I promise you, these are guaranteed test questions. First, steroids cause gluconeogenesis. Translation, hyperglycemia. You must monitor their blood sugar levels, yes, even in your non-diabetic hospitalized patients. Second, they cause massive immunosuppression, meaning your patient is at a super high risk for infection. Third, if they're using an inhaled steroid, they absolutely must rinse their mouth out after every single use to prevent oral candidiasis, also known as thrush. And finally, the golden rule of steroids. Never, ever let a patient stop systemic steroids abruptly.
Let's see how this builds into our next class. Leukotriene receptor antagonists, or LTRAs, with montelukast being the absolute star player here. This is an oral medication, usually just given once daily. It works by blocking leukotrienes, those annoying little inflammatory molecules that cause bronchoconstriction and mucus production. Now, just like our Labus, montelukast is for long-term maintenance and prevention of asthma. It is absolutely positively not for acute rescue. In fact, it takes about a week of taking it to even see symptom improvement.
All right, let's test that critical thinking with our anti-inflammatory drills. Question 1. Why would your totally non-diabetic patient on prednisone suddenly need insulin? Because steroids trigger gluconeogenesis, spiking that blood sugar right up. Next scenario. You're teaching a patient on long-term steroids. What is the priority? You've got to tell them to avoid large crowds and sick people due to that immunosuppression. Now, what if your patient takes an inhaled corticosteroid? Simple. They must rinse their mouth with water immediately after to prevent a fungal infection. Imagine a patient having an asthma attack who desperately reaches for their montelukast pill. What's your intervention? You stop them immediately. It's for maintenance, not rescue. Finally, why must a patient taper off their prednisone? To allow their own adrenal glands time to wake back up and resume natural cortisol production, which prevents a full-blown adrenal crisis.
Section 3. Antitussives. Controlling the cough. Moving away from asthma and COPD, let's talk about coughs. Now, coughing is normally a great physiological function to clear the airways. We like a good productive cough, but sometimes it literally does more harm than good, and that is exactly when we step in. When deciding how to control that cough, you're generally choosing between opioid and non-opioid antitussives. Both of these actually work directly on the cough center located in the medulla of the brain to suppress that cough reflex. Opioid antitussives, like codeine, are highly effective, but man, they come with some severe baggage. You have to monitor for dependency and, critically, respiratory depression, especially in frail older adults. Non-opioids like dextromethorphan are a lot safer, but still suppress that same reflex. But here is the most important takeaway for both of them. They should strictly be used for dry, non-productive, or actively harmful coughs, like, say, right after a hernia repair where coughing could pop some stitches.
All right, last set of drills, let's finish strong. If a patient has a thick, yellow, highly productive cough, do you give an antitussive? No way, absolutely not. We want them to clear those secretions out. Antitussives are strictly for dry, non-productive coughs. Now, what is the single most dangerous adverse effect of an opioid antitussive? Respiratory depression. Always, always assess their respiratory rate. So naturally, what's a relative contraindication for those opioid cough syrups? A history of opioid dependency, for sure. And where in the body do these antitussives primarily work anyway? The central nervous system, specifically targeting that cough center right in the medulla of the brain. And finally, for an elderly, frail patient who is prescribed an opioid antitussive, what is your absolute nursing priority? Close monitoring for excessive sedation and respiratory depression, because they are incredibly sensitive to these drugs.
To wrap up this explainer, I really want to leave you with a provocative critical thinking question that ties this all together. What life-threatening condition occurs if a patient abruptly stops their long-term prednisone therapy? Think deeply about the negative feedback loop here. Exogenous steroids actually cause the patient's own adrenal glands to atrophy and just completely stop producing natural cortisol. If you take away the medication suddenly, the body has zero cortisol left to manage stress. This causes a massive, life-threatening drop in fluid volume, severe hypotension, and shock. This is called an Addisonian or adrenal crisis. Understanding the why behind the pharmacology, like knowing why that happens, is exactly what makes you an exceptional nurse. Keep studying hard, trust the process, and I will see you in the next explainer.